So we'll go ahead and get started while they're gathering. So I'm Robert Carlson from the National Comprehensive Cancer Network. Over the last day and a half, we've been hearing about the development of advanced technologies that really represent modality technologies, specifically for delivering radiation and for performing specialized surgeries. We've heard presentations on the efficacy, safety, and cost of these technologies. We've heard about the regulatory requirements, adoption and de-adoption issues, incentives and disincentives for use, how advanced technology may or may not be advanced care. We've heard about training, credentialing, privileging considerations and challenges. We've heard this morning about the needs and difficulties of developing meaningful evidence. And we've heard about the dissemination and expansion issues and challenges of utilizing the advanced technologies. So this panel of 5 are going to bring all of those together for us, and also to talk about potential solutions for these challenges. So we'll be starting, we will have a brief presentations from each of the panelists, and we'll be starting with Sean Tunis of the Center for Medical Technology Policy. Sean.
All right, well, thank you. These have been a bunch of great sessions, and I guess this is the how do we fix it session. So, you know, from our pre-brief, we've pretty clear that the panel doesn't know how to fix it, but, you know, we'll have a lot of time for discussion, so you all can tell us. But, so listening kind of on the internet yesterday, I was listening to some of the presentations and, you know, about robotic surgery and proton beam therapy, and it kind of brought to mind a kind of a phrase that at least I've heard a number of times called Buxton's laws. It says it's always too early to evaluate medical technologies until suddenly it's too late. So that's we've heard a number of kind of descriptions that fit that, you know, fit that problem, and you know, Anthony Zeitman's kind of enthusiasm slide, you know, says the same thing. I think there's actually a more modern version of this, which is, you know, the Spears corollary, "Oops, I did it again." That's Britney Spears, 2000. I don't know if you're familiar with that song, but, you know, it's the kind of the, you know, "Oops, I did it again," robotic surgery, proton therapy. The idea is, you know, but the interesting thing about this is it's you know, it's this kind of phrase is like, well, I'm kind of sorry, but I'm kind of not. It's just the way that I am. And I'm kind of thinking, actually, that's just sort of the way the health system is, right? We could put up with this. I'll say, to be perfectly honest, if you think about it, a lot of people benefit from this approach to adopting new technologies with very little evidence, and you know, and sort of promoting, you know, overly promoting new technologies, right? A lot of people make a lot of money off that, and it's not just money. It's, you know, patients like it. It's, you know, it's ways for provider institutions. So as part of, I'm raising that because as part of what we have to think about when we're talking about solutions is, in whose interest is it really to do something different than we do now, given how many people actually benefit significantly from, you know, this kind of evidence-free, hyper-enthusiastic, you know, approach to developing and disseminating new technologies. And I think we need to be a bit honest about that if we're really going to think about useful solutions. So let me talk about what I heard as a few kind of key themes that actually resonated for me that I think need to be kind of further pursued to put together some kind of coherent approach that I think would actually be better, more responsible, better for patients, better for, you know, the health system. So, you know, I'm kind of, you've probably all heard of, you know, any kind of services or consulting. It's like you can have 2 out of 3 of these. You can have something that's fast and cheap, but it won't be good, or you can have it good and fast, but it won't be cheap. In healthcare, and I think the kind of the overarching conceptual framework of what we're trying to do that makes this so difficult is we're actually trying to have simultaneously optimize across 3 dimensions: good quality evidence about effectiveness, innovation and rapid access to new technologies, and value and affordability. And if you try to think about it, it's really difficult to optimize across all 3 of those. You know, you can have sort of innovation and evidence, but it won't be, you know, it won't be cheap, and et cetera, et cetera, et cetera. So again, as we're thinking about solutions, you have to think about what's going to get us the best balance of, good evidence for decision making, kind of robust innovation and uptake of new technologies, also, but in the context of recognizing that the healthcare system is looking for greater value. So so that I think is kind of an overarching framework. So briefly touch on three things that, and I mean very briefly because we're trying to sort of get to the discussion, is what I think we need to actually sort of do more work on is some consensus on a methodologic framework, and you've heard a lot about methodology here and some of the challenges of randomized trials versus other, but so consensus on a framework, what I call adaptive reimbursement policy, which we've heard a lot about, but the need to actually somehow align reimbursement with this whole evidence generation process and the realities of the time and cost involved. And then critically important, I think, real-world research infrastructure. By that I mean the ability to learn something useful from 97% of patients treated rather than the 3% of patients treated who now go into clinical trials. But if we actually limit our knowledge generation, evidence generation to the 3% who enroll in trials or 5% or whatever it is, we're not going to make a dent in the number of questions that we really need to answer. So I think this issue of how do we equip the healthcare delivery system to actually more efficiently generate evidence, I think is a key piece of this in answering some of the questions that we're looking at. So consensus on methods. We've talked a lot about whether are the RCTs, they're about 65 years old, now 67 years old. The first modern RCT was 1948. They look good in the 70s, but I'm not sure how good they look now. So, as the randomized trial, is it like ready for retirement? Are we looking for, do we really need to come up with new models? I don't know. I just wanted to put in a picture of the Rolling Stones. Somebody actually told me that that can't be the Stones in the 70s because one of the members of the band is not correct, but I don't know. I wasn't expecting someone would have that intimate knowledge, but let's just say it's about the 1970s. I won't go into that. It's just to say the unfortunate truth is sometimes actually you absolutely need randomized trials to get a right answer, and sometimes they actually have to be randomized trials with sham, with sham control. And the problem, the unfortunate truth is, sometimes with anything short of a randomized trial, you get the answer wrong. On the other hand, as we know, that they're slow and they're expensive, and the kinds of trials that we've been hearing about for the last couple of days are incredibly important, and they will eventually get the right answer. But by the time the answer comes out, it's sort of like game over, right? It's either all the important decisions have been made. We're on to the next generation of technology, and somehow, I think it's really important to think about methodologies that actually have a way of generating evidence that's in some way, consistent with the kinds of decisions and the evolution of healthcare. Anyway, someone yesterday mentioned the ideal framework. It's a nice body of work that kind of lays out a series of increasingly rigorous study designs of surgical interventions and procedures from idea to development to exploration, assessment, and long-term monitoring. And they have sort of different recommendations for study design for each of these phases that are progressively more rigorous. I think the key thing, to get, for example, payers and policymakers to buy into this whole sort of as partners in the evidence generation strategy is to actually have some consensus around a methodologic framework that's systematic and well-defined, and then make sure everybody follows it. Okay, because I think part of the reason that payers are reluctant to partner in the evidence generation process is they hear, many different ideas about what's ready for what kind of evaluation when, and I think if there was a recognition that there was an accepted framework, that the professional societies kind of lived by it, that clinicians, practiced according to this, that would go a long way towards enhancing confidence. The adaptive reimbursement policy, and this is basically coverage with evidence development or other variations of that, but the idea that recognizing that, the accumulation of certainty about the risks and benefits of new technologies is a continuous function, and there's an artificial notion that at some magical moment it goes from being investigational to being medically necessary. That's clearly a fiction, and yet that's the sort of the fiction that payers live by when they talk about sort of rules of evidence. But clearly having policy mechanisms that are more flexible and adaptable that allow for, say, as Jason, as you described, coverage of emerging technologies in the context of clinical investigation is incredibly important. The problem is that coverage with evidence development, nice concept, incredibly difficult in terms of implementation. The Medicare statutory authority for this is extremely weak. Private payers, with a few exceptions, are not generally enthusiastic. These projects are incredibly labor intensive. And, as I said before, they kind of depend on having some agreed upon methodologic framework to begin with about when a technology is ready for this, et cetera, et cetera. So you can't have a viable CED framework unless you actually also have some sort of methodologic framework that people agree to. And finally, the research infrastructure, people know about probably the Patient-Centered Outcomes Research Institute is creating this PCORNet, which is Patient-Centered Outcomes Research Network, which is kind of an integrated electronic medical record and claims network that's supposed to be a kind of a real-world platform for conducting observational studies and experimental designs. They're very clear that the intention is that this would be a platform for conducting very large, fast and cheap, randomized pragmatic trials. And I think whether, the NCI or, the existing clinical trials infrastructure in radiation oncology, could kind of build on the model that I think Justin Beckelman's PCORI grant is moving towards, which is using the existing research infrastructure, but adapting it to become more amenable to large, fast, cheap, simple randomized trials. I think that's got to be a piece of this as well. So again, just sort of those at least those three components I think have to be worked on simultaneously and integrated, which is a methodologic framework, adaptive reimbursement policy, and then an infrastructure that allows these studies to be done much more inexpensively and rapidly.